Very well. I think we will start the webinar at this point. I'm Daniel Lenahan. I'm the past president of the International Cardio-Oncology Society, and I'm greatly honored to be involved in this year-long four-part webinar series regarding cardiovascular disease and prostate cancer. This session is actually the fourth of our four-part series, and we've had three other webinars that were really fantastic and covered many of the contemporary issues in cardiovascular disease as it relates to prostate cancer and its treatment. I want to thank Ferring for their support and Duke Health for their great organization of this webinar series. I also want to thank my co-moderators for the whole series, Darryl Leong, who will be giving a lecture later on today. He is the director of the Cardio-Oncology program in Hamilton Health Sciences, and Renata Lopez, who's a professor of medicine at Duke University. This series really has been an outstanding review of contemporary research and clinical practice, and it is truly an international effort done in conjunction with the Canadian Urologic Society and the European Association of Urology. I want to hand over this current webinar to Renato Lopez, who will introduce the speakers and go over what we're going to cover today. Thank you.
Thanks, Dan, and welcome everyone for our last webinar from this series. Really exciting one, talking about the future and what's happening in the near future that we need to be all expecting in the near future. And to start and to kick off the meeting, I would like to introduce the next moderator that will moderate the first section or the first lecture, which is Dr. Diogo Bastos. He's a GU oncologist from the Hospital Sírio-Libanês in São Paulo, Brazil. So Diogo, it's our pleasure to have you here, and I'll give you the word.
Thank you so much, Renato, for the introduction, and also thank you for the invitation to be here. It's my pleasure. We'll have three wonderful talks regarding prostate cancer and the multidisciplinary approach in terms of the disease treatment, but also in terms of the multidisciplinary view on the cardio-oncology perspective. So it's my pleasure to introduce Dr. Anthony Yang, who is a professor of the Division of Urology from the Department of Surgery from the Chinese University of Hong Kong, who will co-moderate this session with me.
Thank you, Diogo, for the introduction. It's my pleasure to representing Asian in joining this meeting, and good afternoon to all of you. And so, without further ado, I will start introducing the first speaker, Dr. Alberto Briganti. He's the Associate Professor of the Urology from the Università Vita-Salute, San Raffaele, Milan, Italy. And so today he will present us what's next in prostate cancer research, and he's pre-recorded a video from him.
Okay, so now move to the next talk. But before that, I'd like to remind you that if you have any questions, please feel free to submit those to the Q&A so we can discuss at the end. So now it's my pleasure to present Dr. Susan Dent. Dr. Dent is the president of the International Cardio-Oncology Society and co-director of the Cardio-Oncology at Duke University, and she will talk about lessons learned from breast cancer about multidisciplinary management of the disease. Dr. Dent, thank you so much.
So, dear colleagues, it's my true honor and pleasure for me to be here today to talk about novelties and new areas on prostate cancer research. My name is Alberto Briganti. I'm professor of urology at the Department of Urology, Vita-Salute University, Milan, Italy. These are my disclosures. So in the agenda, I will touch upon three different topics. One is the areas of research in terms of perioperative treatment intensification The second topic would be metastasis-directed therapy in metastatic hormone-sensitive prostate cancer, and the third one being PSMA ligand therapy. So in the era of intensification therapies for radiation therapy, for example, we are also experiencing and evaluating novel research approaches for intensification treatments prior to and after radical prostatectomy. Over the last years, there has been indeed numerous attempts to increase the rates of clinical recurrences, for example, in patients with high-risk disease, by giving neoadjuvant androgen deprivation therapy with the aims of improving local control and of eventually sterilizing some foci of micrometastatic prostate cancer. And of course, it's also a paradigm for evaluating the activity of new treatment modalities. But we know that upfront, patients, if are correctly staged with the proper imaging modalities, patients with high-risk disease, they do have a certain amount or certain rates of a micrometastatic dissemination, both in the bone and in the lymph nodes. This is up to 40%. And over the last years, several studies have indeed tried to assess and evaluate the role of neoadjuvant androgen deprivation therapy prior to radical prostatectomies, but they virtually all failed in the attempt of improving strong clinical endpoints like clinical recurrence and overall survival. So several parameters have been improved, like pathological data and pathological parameters, but no impact on strong oncological endpoints. And this is the reason why in virtually all guidelines, including our EAU guidelines, do not consider or do not recommend absolutely the use of neoadjuvant ADT prior to radical prostatectomy in any disease setting. However, is this due to some sort of inaccurate patient selection for those receiving neoadjuvant ADT in these studies? Is this due to unpowered studies or lack of long-term follow-up assessments? Or is this due to possible incomplete tissue androgen suppression? And the ideas will be then to increase the intensity of androgen suppression in the tissues with the aim to improve patient outcomes. And this is why in the current areas of research of perioperative treatments intensification, ADT has been indeed tested and is currently being tested with several androgen receptor targeted agents of novel generations like abiraterone, enzalutamide, apalutamide, or darolutamide, or even the combination of double androgen receptor targeted agents together with ADT. And several studies have indeed been published, and these are mainly small phase 2 studies, some of these again being prospective and well performed, with a final aim to assess whether treatment intensification prior to surgery with ADT plus androgen receptor targeted agents was able to improve pathological outcomes. And the main endpoints of these studies being complete pathological response or minimal residual disease at radical prostatectomies. These studies are several, and some of these are currently ongoing, but the main message is that from these studies, we can say that by using a combination therapy with ADT plus androgen receptor targeted agents, we have a lower intratumoral androgen concentration. There is a trend toward higher rates of minimal residual disease and pathological complete response for those receiving combination treatments with a lower median residual cancer burden. However, androgen receptor targeted agents alone are less efficacious than the combination of treatments, and it seems that there is no additional benefit of further intensification with double androgen receptor targeted agents plus ADT. And these are the current studies that are actually ongoing, testing different drugs in the setting of neoadjuvant therapies prior to radical prostatectomy, mainly in patients with high-risk disease. And the biggest studies which will be released, at least for some of these outcomes relatively soon, is the Proteus trial. And the Proteus trial is the very first phase 3 prospective randomized study that indeed randomized patient to ADT plus apalutamide versus ADT plus placebo prior to radical prostatectomy. These treatments actually is not limited to the time prior to surgery, but it is also it's a true perioperative approach with the main endpoint being pathological response, but also oncological outcomes. And we are looking forward to receiving at least the initial results of this study. There is also another attempt to use other therapies prior to radical prostatectomy with the aim to improve patient outcomes. And we are now in the era of lutein PSMA, and this has been tested also prior to surgery in 2 small phase 1/2 studies that included patients with localized high-risk disease or local advanced prostate cancer, number of cycles being 1, 2, 3, and the primary endpoints being either absorbed radiation dose or safety. These studies have tried to elucidate possibly the role of this treatment approach prior to radical prostatectomy, and actually, these studies showed something which is interesting. So there is indeed a clinically meaningful dose absorption by the prostate, but the response in terms of pathological outcomes at radical prostatectomy seems to be a little bit suboptimal. There is some reductions in PSA, but actually these cannot be in any way used to confer or to assess or to state any significant benefit on oncological outcome. These are only very preliminary results. And the other studies show that there is no increased rates of perioperative complication or intraoperative complication. So both of these studies actually have tried to shed lights on the possible use of lutein PSA prior to surgery in the setting of treatment intensification. But the future of perioperative intensification treatments is not a one-size-fits-all approach. The treatments of the future will be anyway, I believe, tailored according to each patient profile. And there will be indeed the need of assessing individual mutations or individual genetic predisposition of patients. And by using these NGS, we can actually tailor the proper treatment for each specific patient profile according to genomic or genetic findings, which will somewhat drive the use of perioperative treatments prior and after radical prostatectomy. The second topic is actually metastasis-directed therapies in metastatic hormone-sensitive prostate cancer, which is actually a hot topic. We as urologists or physicians are facing every day patients coming in the office with novel imaging approaches like PSMA PET with a few spots either in the nodes or in the bone. And this is the so-called oligometastatic prostate cancer, which seems to be a new entity for 2 main reasons. First, we are understanding more and more its biology. And second, we have more sophisticated imaging approaches, which anyway anticipate the diagnosis of oligomet disease as compared to a conventional imaging. Now, when we apply metastasis-directed therapy in the setting of metastatic hormone-sensitive prostate cancer, there are 2 main settings. One in patients with synchronous oligometastatic disease and patients with metachronous, so recurrent oligometastatic prostate cancer. That's the first setting, which includes patients with synchronous oligometastatic disease. We do have very limited data whether targeting also what is seen at PET is beneficial for patients. There is no prospective randomized studies, and actually there is no recommendation from the guidelines to use this metastasis-directed therapy approach in the upfront treatment of patients with metastatic hormone-sensitive disease. It's a bit different the situation when we talk about metachronous oligometastatic prostate cancer, which still, in terms of metastasis-directed therapy, needs to be considered experimental until the results of RCTs will be available. And this is what is currently stated by the EU guidelines. Now, we all know that treatment of the primary is beneficial in terms of strong oncological endpoints for patients with oligometastatic prostate cancer at presentation, even though scanned by conventional imaging. This is the very well-known STAMPEDE study that showed the beneficial effect of treatment of the primary in the setting of oligometastatic prostate cancer. However, we need to have more data because we do not know yet whether there is a beneficial effect of targeting together with the primary also, as we were mentioning, the metastatic deposits seen at functional imaging. And we do not know whether, for example, radiation therapy is superior to radical prostatectomy as a primary therapy of prostate cancer. And these are two main endpoints or two main issues which will be assessed in the so-called trial M of the Stampede, which will have different endpoints and which will look at different views, whether or different data, whether indeed treating the secondary deposits is beneficial or whether surgery is worse or equal to radiation therapy. In the setting of oligorecurrent metastatic prostate cancer, the situation is a bit different, as we were mentioning, because there are initial evidences that treatment of the metastatic deposits seen at functional imaging is beneficial in terms of delaying the time to androgen deprivation therapy or in terms of early progression-free survival rates. But these, again, are phase 2 studies which included kind of weak endpoints as primary endpoints of the studies. In the questions which these two studies have not addressed yet is whether, if we go for metastasis-directed therapy in the oligorecurrent disease, should we add on it androgen deprivation therapy? And the answer is still unknown. There is some retrospective evidence like the one I'm showing in this slide, in which there is a beneficial effect of giving long-term ADT together with MDT to the metastatic sites. But this, again, retrospective evidence. We need more prospective randomized data. And this is one of the examples of the study which has just started, which will address the role of ASBRT to the local regional regions seen at PET-CT, together with all pelvic salvage radiation therapy with or without combined ADT plus apalutamide. So there is actually a need to understand how much treatment intensification should be given to these patients when metastasis-directed therapy is concerned. Finally, the third areas of great interest of research will be certainly implemented in the next years is the role of PSMA ligand therapy. So as we know from the guidelines, lutetium PSMA, which is a form of PSMA ligand therapy, as we know, is currently recommended in highly pretreated patients with metastatic castration-resistant prostate cancer with one or more metastatic visible lesions highly expressing PSMA. The main recommendation, which I just mentioned, is mainly based on the so-called VISION trial. And the VISION trial is a prospective randomized study that actually showed that it was a beneficial effect on these treatment as compared to standard care alone. However, there are several reasons why this kind of treatment might not be beneficial, and actually there are indeed possible reasons why, like heterogeneity of tumor PSMA expression or the distribution of the disease, failure to deliver a lethal radiation dose, and tumor mutation factors. And we all know that there is indeed highly heterogeneous expression of PSMA both intra the tumor itself and within the same patient. So this is one of the reasons why the treatment might not be efficacious in all patients. And there is now evidence that we can combine this approach with additional drugs, like drugs we can block the androgen receptor, which might act as synergistic drugs together with lutetium PSMA. The same applies to immunotherapy, since this approach may increase the release of new antigens and actually improve the efficacy of immunotherapy. So, having said this, this is one of the main areas of research where I believe there will be future implementation, and I believe that in these three areas we will see more and more data, and prospective combination therapies will certainly be the key to improve patient outcomes. So thank you very much for your attention, and I wish a nice webinar.
Okay, so now move to the next talk. But before that, I'd like to remind you that if you have any questions, please feel free to submit those to the Q&A so we can discuss at the end. So now it's my pleasure to present Dr. Susan Dent. Dr. Dent is the president of the International Cardio-Oncology Society and co-director of the Cardio-Oncology at Duke University, and she will talk about lessons learned from breast cancer, about multidisciplinary management of the disease. Dr. Dent, thank you so much.
So thank you for inviting me. And today I was asked to talk to you a little bit about what lessons we've learned in the breast cancer community and how we can apply that to the multidisciplinary treatment approach to patients with prostate cancer. So what I'd like to do over the next 15 minutes or so is briefly talk to you about some of the lessons that we've learned about the risk and management of cardiovascular toxicity in patients with breast cancer, and to discuss how we can use that knowledge to optimize care of patients with prostate cancer. And finally, talk a little bit about multidisciplinary approach to the management of cardiovascular risk in all patients with cancer. So these are my disclosures. I do not have any relevant disclosures for this talk, other than to say I am not a prostate cancer oncologist and I'm not a cardiologist, but I certainly will give you my viewpoint on how I think we can learn from the breast cancer community and apply some of those principles to the care of patients with prostate cancer. So what we've learned about cardiovascular toxicity in breast cancer over the years, it is not only about anthracyclines. And when you speak to a lot of my breast cancer oncologist colleagues, they'll say it's only about anthracyclines, and we know that causes heart failure. And we know sometimes you can get into trouble with trastuzumab, and that can cause drops in left ventricular ejection fraction. But as we've seen the evolution of breast cancer therapy over the last several years, there are a number of other compounds that are now being used in the clinic that can cause problems beyond drops in LVEF and heart failure, such as the PI3 kinase inhibitors, which can cause hyperglycemia and metabolic syndrome. CDK4/6 inhibitors can lead to QTc prolongation, particularly with ribociclib. And we, of course, now have checkpoint inhibitors that are used in the treatment of triple-negative breast cancer that can lead rarely, although if it happens, can be quite severe myocarditis. So it's not just about heart failure anymore, and it's not just about anthracyclines. I think what we've learned also is it's not just the drugs. So as an oncologist, when I see these patients in the clinic, I think about what kind of treatment I'm going to give them, whether it be chemotherapy, immunotherapy, plus or minus radiation at some point. But we now understand that it's actually all of the things that we have to take into consideration in that individual, including their age, cardiovascular risk factors, pre-existing cardiovascular disease, and then some of their lifestyle issues, such as inactivity, obesity, smoking, and so on. All of these things we know can lead to cardiovascular mortality and morbidity in survivors if we don't manage them throughout the cancer journey. And so when we think about how we've practiced and how we've treated cancer patients, I would argue that we have really practiced a very disease-centric approach to our patient care. And in this article that we just published in JACC Cardio-Oncology this year, we are advocating for a more person-centric model, whereby we look at that individual, their genetics, their lifestyle behaviors, environment, and social determinants of health, and we determine when that cancer was diagnosed, what type of cancer therapies they're going to be exposed to, and how that fits into their risk in terms of what they have pre-existing, and or how does that therapy going to impact their overall cardiovascular risk down the road. And so management of cardiometabolic morbidities associated with cardiovascular disease, I think, is becoming increasingly essential, not only during, but after cancer therapy. So how do we do this? I would argue a team-based approach. And while that seems intuitive, I would argue that in medicine, we still often practice in silos where we have our cardiologists, our oncologists, our primary care providers, and so on. And in fact, when you look historically, primary care providers are not part of the oncology team, and patients don't tend to go back to see their primary care providers when they're on active cancer therapy. So if we are thinking about how to look at the whole person and manage cardiovascular risk, I think it's very important that we consider all of these healthcare providers in terms of the strategies about how to manage that risk. So 2 different cancers, prostate and breast cancer, and I was thinking about this when I was putting together this talk, but really they share common cardiovascular risk factors. So we see that breast cancer and prostate cancer are both occur in older age. Many of these patients may have pre-existing comorbidities such as hypertension, dyslipidemia, and diabetes, and we're exposing them to potentially cardiotoxic cancer therapy. This then places both of these groups of individuals at increased risk of both cancer and non-cancer related morbidity and mortality. And so just to give you a flavor of what we see when we look in general at the cancer population versus the non-cancer population and comorbidities, that cancer patients in general have a disproportionately higher burdens of comorbidities, that when we look at those individuals aged 65 years and older, they often have pre-existing hypertension when they're diagnosed. They may have dyslipidemia as well. And in fact, they're overall, and cancer survivors are more than 1.4 times as likely to have a history of diabetes. We then expose them to agents that can exacerbate those underlying comorbidities, and that can lead to excessive cardiovascular mortality down the road. So let's just look at breast cancer. I want to highlight, we've done a great job in treating breast cancer. Now 5-year survival rates exceed 90%, 99% for localized disease. But most women will have at least one cardiometabolic comorbidity at the time of their diagnosis. And so when you see this, these curves here, this is a postmenopausal population, but at 7 years in this group of women that were over 65 at the time of diagnosis, cardiovascular disease exceeded breast cancer as the cause of mortality. But what about prostate cancer? Well, we know, I don't have to tell this audience, it's common. It's the second most common cause of cancer death in US men. But interestingly, when you look at this graph, you'll see that cardiovascular mortality is now the leading cause of death in patients with prostate cancer. So we're doing a great job at treating prostate cancer, but we can't forget about cardiovascular morbidity and mortality. And this just to point out, this is a slide borrowed from one of my colleagues here at Duke, that these patients are living for a long time with prostate cancer, and they're being exposed to a number of different agents, cancer agents on top of their comorbidities. And so hence they're at risk for a longer period of time of experiencing a cardiovascular event. So we always have to think about how do we balance the cancer treatment and against the risk of cardiovascular disease, and how does that balance look in individual patients? And so this is just an example when we're talking about endocrine therapy, and I relate to this because of what we do with our prostate cancer patients, but we know that endocrine therapy results in cardiometabolic effects on our cancer patients. So for instance, aromatase inhibitors, commonly used both in the adjuvant early stage setting as well as in the metastatic setting, can change body composition, hepatic fat, glucose metabolism, can increase lipid metabolism, and are associated with an increased risk of cardiovascular events. Now, in a study looking in the UK and the US, looking at data published a year ago or so, we know that some of that is because these agents were compared with tamoxifen users, and tamoxifen has a bit of a cardioprotective effect, but suffice to say that there are changes in how these patients act in terms of their metabolism and what we give them. And so based on that, in the recent European Society of Cardiology, Cardio-Oncology guidelines, they recommend a baseline risk assessment and monitoring during endocrine therapy for patients with breast cancer, including a baseline cardiovascular risk assessment and estimation of the 10-year fatal, non-fatal cardiovascular risk, as you see here. And so that's using the SCORE and SCORE2 approach, and listed at the bottom of this table here. And if we look at prostate cancer similarly, and the effects of ADT, we can see that it does also impact body composition by increasing body fat, decreasing muscle strength, increasing triglycerides, LDH, and total cholesterol, and increasing arterial stiffness. So some of the things that we see in women and how endocrine therapy impacts women are also occurring in men exposed to ADT therapy. And when we look at the newer agents, the next generation hormonal therapies, although they've only been in the clinic for about a decade, there does appear to be an increased risk of cardiovascular toxicity with both the conventional ADT and next generation hormonal therapies. And although this risk may be highest in the first 6 months of therapy, at least that is thought to be the case, particularly in those with at least one prior cardiovascular risk factor, we're still learning about the impact of these in the prostate cancer survivors. So in this communication with a colleague of mine, Dr. Harrison, he suggested we should consider referral for aggressive cardio risk management by cardiologists before ADT and HT is started in high-risk men. And in fact, if you look at the guidelines again, just published earlier this year, you'll see that there are recommendations for baseline risk assessment and monitoring during anti-androgen deprivation therapy for prostate cancer at baseline, and baseline and serial ECGs in patients at risk for QTc prolongation during AT therapy. So we're starting to see more movement towards thinking about what is the risk at baseline. How do we evaluate that risk prior to starting men on the most appropriate cancer therapy? And so when you're thinking about management of cardiovascular risk in the prostate cancer population, this is perhaps one model that you can look at that was recently published in JACC Cardio-Oncology. Think about whether that individual has a localized prostate cancer or advanced prostate cancer, and what are their underlying comorbidities. Then you can consider what treatment are you going to offer them, and what risk does that put them in terms of their overall risk. And then we need to think about monitoring and maybe modifying some of those risks. So lifestyle interventions, as well as perhaps pharmacological treatment of some of their cardiovascular risks. And then of course, following guidelines and referring them when appropriate to our cardio-oncology colleagues to help with management of some of these cardiovascular risks as well. And so, overall, when I thought about this topic of breast cancer and prostate cancer and how do we manage these cardiovascular risk of these populations and lessons learned, I think what we're seeing is that the modern cancer therapies, even though they continue to evolve, we really made significant gains in the clinical outcomes of our patients. But we can't do that at the expense of causing more cardiovascular risk or morbidity. So cardiovascular risk assessment, I think, is important, and one could say essential for all patients prior to, during, and after completing cancer therapy, if we're going to be able to sustain the gains that we're making in cancer therapy for our patients. And clearly a multidisciplinary approach, team-based approach is needed to optimize both cancer and non-cancer related outcomes. So with that, I'll conclude, and thank you for the opportunity to speak to you today.
And thank you, Dr. Dent, for your sharing. And we will save the question and discussion at the end of this presentation. And so we will come to the first presentation of this seminar, and it's presented by Dr. Darryl Leong. It's an associate professor of the Department of Medicine, McMaster University of Canada. And the topic that Dr. Leong will present is enhancing the CV cardiovascular and prostate cancer survivorship. So Dr. Leong, please.
Thank you very much to our chairs, and it's a pleasure to be with you today to speak on this topic for ICOS. Here are my disclosures relevant to prostate cancer, especially as it pertains to cardiovascular outcomes. So over the next 10 to 15 minutes, we're going to present to you a conceptual framework of cancer survivorship, and more specifically prostate cancer survivorship, discuss how survivorship issues pertain to androgen deprivation therapy, as Dr. Dent has already laid the case nicely, and finally touch on the potential role of exercise as an important adjunct to the treatment of patients receiving androgen deprivation. So what is a cancer survivorship, and perhaps more specifically prostate cancer survivorship? The truth is, I think, that this is an evolving concept. And the reason it is evolving is that treatments are continually evolving and patient survival is continually increasing. Some might define survivorship from cancer as survival of at least 5 years after a definitive therapy, after diagnosis. Others might define survivorship as occurring or beginning from the point of diagnosis. And some, including patients themselves, might actually not even support the use of the term survivor, because as one patient expressed, having cancer survivor as a term actually defines an individual, and this may not be desirable, and one can certainly empathize with that. So rather than just defining what survivorship with prostate cancer is, the American Cancer Society describes certain cancer survivorship trajectories, and they can be applied to those who are either free of cancer because they've had a definitive therapy. Hopefully, they may be free of that cancer for the remainder of their life, but as Dr. Dent illustrated, they may survive with complications of the cancer therapy. And of course, the cancer can recur at a later time point, or indeed, these patients can develop a second cancer or another competing risk, which can interfere with their quality and duration of life. And of course, we need to consider those with an ongoing persistent cancer, which may require intermittently periods of treatment and active disease, or they might have a somewhat more progressive and ominous course. So how do these cancer survivorship trajectories apply to prostate cancer specifically? This will be known to those who treat patients with prostate cancer, maybe a little less familiar to the cardiologists in our audience. But you can see that treatment strategies may include active surveillance, a definitive therapy such as radiotherapy or prostatectomy, a watchful waiting approach in those who are not perhaps candidates for more aggressive therapies. And of course, there is always the specter of metastatic disease, which may occur de novo or may occur in the context of biochemical relapse after some form of definitive therapy. And at all of these junctures, death is obviously an outcome to be dreaded and avoided, but so too are competing risks, which can also lead to death and poor quality of life. And so androgen deprivation therapy is a key part, a cornerstone of the treatment of advanced prostate cancer. It can feature at a number of points in the prostate cancer survivorship experience. And so I think it is very pertinent that we review some of the potential adverse effects of hormonal androgen deprivation therapy. Shown in this schematic are some of the potential adverse effects of androgen deprivation therapy, including loss of muscle strength, weight gain, fatigue, and there have also been links with depression, perhaps cognitive decline, and of course, erectile dysfunction is very clear. But what I think is important to note is that the strength of the evidence to support some of these associations is, when you look at it more closely, surprisingly modest. And it's surprising because the potential implications of these adverse effects are substantial. Up to 40% of men with prostate cancer may at some point in their survivorship experience be treated with androgen deprivation therapy. And so these adverse effects could affect a very large proportion of what is obviously a very common cancer. Also interesting to note that cardiovascular disease features many of these complications as well. And so there is a clear overlap in terms of quality of life and these various survivorship issues between cardiovascular disease and prostate cancer. So it would be impossible really to cover all of these potential survivorship issues during the course of this webinar. And so for the interests of time and cardio-oncology as a focus, we're going to concentrate a little on the change in anthropometrics and the role of exercise. Here's some early work by Dr. Smith illustrating what happens if you treat men with leuprolide, the GnRH agonist here, for prostate cancer. You can see that in these 26 individuals, weight and waist circumference did increase by about 3 to 4% during a 12-month period. There are important limitations to these data. Firstly, there was no control group, I suppose, so we are uncertain to the extent to which change in anthropometrics shown here may be simply a reflection of the state of life or stage of life that these patients are in, or that occurs in men with prostate cancer in general. Also, the measurement of weight and waist circumference doesn't necessarily factor in what happens to muscle mass and muscle strength. We showed a few years ago now that muscle strength measured simply with a hand grip dynamometer is a very potent predictor of clinical outcomes, including mortality, cardiovascular death, and myocardial infarction. And importantly, if you develop one of a wide variety of illnesses shown here on the figure on the horizontal axis, low muscle strength is a clear risk factor for mortality within a period of time following the development of these illnesses. So low muscle strength confers vulnerability to adverse outcomes, and this is obviously important in cancer survivors. So with this in context, we started to look at the change in anthropometrics among nearly 2,500 men with prostate cancer in a large ongoing cohort study called Radical PC. What you see on the left is that in comparison with prostate cancer patients not receiving androgen deprivation therapy, those who do have an acceleration in central weight gain, in central adiposity, but they also have an acceleration in the deterioration of their muscle strength as measured using a hand grip dynamometer here. And this is not accounted for by a number of other potential confounding factors. So given these changes in anthropometrics that men receiving androgen deprivation therapy are subject to, I guess it doesn't come as too much of a surprise that androgen deprivation therapy is associated with an increased risk of complications of adiposity like diabetes, shown here in this large retrospective United States study of men with localized prostate cancer, where ADT as a primary treatment was associated with a 60% higher incidence of diabetes during follow-up. In this retrospective study, again from administrative data in Taiwan, we see that androgen deprivation therapy is associated with about an 80% higher incidence of hypertension. And so these cardiovascular risk factors are clearly important. But moving beyond just the presence or absence of cardiovascular risk factors, I think we also need to have a conversation about how well risk factors are addressed and controlled. Shown here are data from the Radical PC study, again, an analysis led by Harry Klimas, looking at how well these 5 cardiovascular risk factors are controlled relative to guideline thresholds that are recommended based on the individual's past history of cardiovascular disease and on their risk factor characteristics. You can see here that the most poorly controlled risk factor is central adiposity among men with prostate cancer, but also featuring very strongly our blood pressure and LDL cholesterol, which were not at target levels in the majority of men with prostate cancer. Now, physical inactivity was present in a fifth of these participants, but you might argue that the definition of what constitutes physical inactivity is somewhat arbitrary. And in fact, there is clear evidence of a dose-response relationship between physical activity and health outcomes. Shown here are an analysis led by Scott Lear, showing in the green sort of markers that compared with low physical activity, those with moderate physical activity have a 15% lower risk of death or cardiovascular disease. And compared with moderate physical activity, those with high physical activity also have about a 15% lower incidence of death or cardiovascular disease. But compared with low physical activity, those with high physical activity have a more marked reduction in the risk of death or cardiovascular disease, highlighting that dose-response relationship. So perhaps not being physically inactive alone is insufficient. What can we do to improve on physical activity then? There have been a number of trials totaling several hundred patients in men with prostate cancer, examining the effects of structured exercise programs on anthropometrics, on lean body mass on the top panel and fat mass on the bottom panel. And as you might expect, these exercise programs do deliver improvements in lean body mass and a decrease in fat mass. So this is the extent of the data in prostate cancer. I think what is needed is, firstly, to understand how this a change in anthropometrics actually influences clinical outcomes, which are relevant to patients and patient-centric, and secondly, how sustainable some of these exercise programs are. But beyond the cardiovascular benefits that you might infer from these sorts of data, shown here are some provocative data from another Canadian group demonstrating that a high intensity exercise program might actually have some sort of positive benefits in terms of prostate-specific antigen, so PSA and PSA velocity, and so leads to the hypothesis that exercise could have favorable effects on prostate cancer natural history. So if we agree that exercise is likely to be beneficial, I think we also need to consider some of the implications for men with prostate cancer specifically. Seeing a lot of these patients, we recognize that there are important barriers to exercise in this patient population. For example, after a radical prostatectomy, exercise is not encouraged for the first several weeks or months to allow for healing, but this can obviously promote deconditioning. A proportion of men treated with definitive therapy will experience urinary incontinence, and this is a big obstacle to men, which they struggle with when they try to exercise. Androgen deprivation therapy, as we've highlighted, causes weight gain and also causes fatigue, and this can be a major obstacle for men trying to exercise. And of course, bony complications from metastatic disease and bone health in general are also important barriers to exercise on top of the normal musculoskeletal changes that occur with older age. So there are a number of unique considerations for men with prostate cancer when it comes to exercise. And so to conclude, I think that the sequelae of androgen deprivation therapy, understanding these sequelae better, are really pivotal in prostate cancer survivorship. While exercise could be an important strategy to mitigate some of the potential adverse effects of androgen deprivation, we really need more evidence to inform exactly what the clinical benefits of exercise programs are and to identify strategies to optimize adherence to exercise, which is a problem not just specific to prostate cancer, but really across the population. And so with that, thank you very much for your attention.
Thank you so much, Darryl, for a great talk. So 3 great talks, and now we have roughly 13 minutes to discuss. So for the audience, please feel free to go to the Q&A and type your answer, or your question or comment. I guess we could start with one comment made on the Q&A, and Darryl, you start answering that. So the comment was, the Canadian guidelines have removed LHRH antagonists as a protection for cardiovascular risks. And then the question is the debate closed? So Darryl, since you already started answering that, would you answer?
Yes, so Pfizer, Myovant have recently announced and published on clinicaltrials.gov a trial that we've been involved in helping to develop called Replace CV, which will be a large head-to-head trial of Relugolix with cardiovascular endpoints in mind there. So this is something which is in process and hopefully will add to the debate rather than see it end here and now.
Yes, actually, there are a number of questions that I would have come up with in regards to our talks today, but since we have Susan on the call, one thing that, sort of generally speaking, obviously, I know your main comfort zone is the management of breast cancer, but what strategies for preventing thrombotic complications or thrombotic risks in breast cancer, related to hormonal therapy, how could we apply those things to prostate cancer? I'd just be interested in your take on that, because although generally speaking, endocrine therapy in breast cancer is for the most part, quite safe overall, there is a metabolic derangement effect that is relatively modest, but certainly the thrombotic risk is increased. What is your perspective on that?
So, I think that's an interesting question, and we're always worried about that, particularly in our patients with metastatic or advanced breast cancer, who then we may put on endocrine therapy, and who may have other risk factors such as atrial fibrillation. So in that case, it really is, well, you have access to aromatase inhibitors. You also have access to tamoxifen in the breast cancer world. I think when we're deciding on which endocrine therapy is best for that patient, you have to take into consideration their risk of clotting. So, are they a person that's had strokes before, they're not mobile? And you have to also look at their cardiovascular history. Do they have arrhythmia disturbances? And that's something that, perhaps in the oncology world, we don't always pay attention to. But I would say that, that risk assessment, or looking at not just only the risk from the drug, but the risk in that patient and and sort of what they have. And then really, reaching out to our cardiologists if we are worried or concerned. What's interesting, I think, about the atrial fibrillation is that we see it so commonly in our cancer patients, but as oncologists, I think we're probably undertreating it, to be honest with you, in terms of the risk of thromboembolic events. But
yeah, and then I'll just add to what Susan mentioned, because I think that's so important, and we have discussed that in basically the 4 webinars that we had. Which first is that I think we need to, as a team here, cardiologists, oncologists, urologists, different specialties, come up with higher quality studies to first assess what these risks really might be. Because what we've learned is that these patients might not be well treated with things that we know already are drugs that can really decrease the cardiovascular risks. And therefore, when you look at a cancer patient treated with X or YZ drug, some of the time these drugs might be getting the blame of their risk or their increased risk in cardiovascular disease. But I think we learned that not all of that risk might be related to that hormonotherapy drugs and things like that, because there are a lot we can do from the cardiology perspective now to really reduce these risks. And maybe if we do that, the leftover risk might not be that high anymore to be attributed to the hormonotherapy or any oncology drugs. So I think that's a major theme that we learn here, and somehow it's a mindset shift from what we traditionally have thought. And I think we need to get together and design better studies to really assess that. And more than that, not only assess that risk, but come up with strategies that we can reduce that together with the well-treated patients from the cardiology point of view as well.
Super. Thank you, Renato. Yeah, that's an extremely important point. And I know you're intimately aware of the PRONOUNCE study. And I think that's honestly, in my view, it's how the cardiovascular disease was managed in that study was so important for reducing the number of events, or at least that's my take on it. But Darryl, I loved your talk, but it does make me wonder, how can we be compelling to our patients about exercise? I mean, we have this struggle in all of cardiology. If we say, yeah, you have coronary artery disease or you have whatever, and we really want you to, do regular exercise at least 3 or 4 times a week for 30 minutes or more, et cetera, et cetera. But in a patient specifically with prostate cancer, you showed, interesting data, but what do you think we could actually tell our patients that would be compelling? What would you say to them to say, this is really important because ABC, whatever it is?
It's such a tough one, Dan. It's a great question. It's an unanswered question. I feel sometimes in my clinic like I'm a personal trainer, just trying to encourage people and push them to do it. But as you know, it's extremely difficult. I think that this does need to be tailored to some extent. As physicians, we need to identify the levers and buttons for particular patients. It may be that, they want to see their grandkids go up. And so you can push on that button and say that this is important to you maintain your health so that you can do that and accomplish your life goals. In other patients, they might have had a cardiovascular event, and that might be a changing event, which, could be leveraged to try and encourage them to adopt healthier lifestyles. But it's extremely difficult. And I think putting on weight from androgen deprivation therapy kind of adds to that cycle of difficulty in getting folks to exercise because they're fatigued and it's hard.
Super.
I just make one comment, Dan. I think that this is so important. And when we talk about, in oncology, survivorship plans, right? And survivorship plans were sort of developed with the idea of what can you do to prevent recurrence. Of course, survivors can be people that are taking lifelong therapy, but what we haven't done, or what we haven't been able to do, sorry, I think I'm frozen there a bit, but what we haven't been able to do is incorporate some of the things we're talking about into survivorship plans, right? Or that. So when we refer these patients back to their primary care provider, or maybe put them in an advanced provider clinic, we really need to think about also advocating and educating patients, not just about getting your mammogram every year, to detect risk of recurrence of breast cancer, but we need to be talking about exercise, lifestyle modification, all of those things. I mean, the cancer clinics have done a great job at stop smoking campaigns, right? That seems to have really been integral into our cancer centers. We haven't done the same thing for exercise, except I will say that when I was in Ottawa, they had an exercise right in the bottom of our cancer center. We had an exercise place, and patients could go right in the cancer center and exercise. And they had exercise physiologists who would prescribe them their exercise treatment plan right in the cancer center. That was
nice. Really yeah, and Dr. Bastos, I wonder, since Dr. Briganti is not live to answer any question, I thought his presentation was really awesome. But what do you think? He mentioned a trial called the Proteus trial. What do you think? What sort of relevant information do you hope will come from that trial, or what things do you think we can learn from a cardiovascular point of view?
Yeah, so my impression is that, I mean, we are heading to a more intensification of treatment in earlier phases of the disease. So now we have trials with ADT plus an oral drug in biochemical relapse, and also now these phase 3 trials concurrently with radiation therapy as primary treatment, and also in the neoadjuvant setting prior to radical prostatectomy. We ran a small phase 2 trial here in Brazil using abiraterone plus apalutamide prior to prostatectomy. And we just published, and we observe a higher incidence of thromboembolic events and cardiovascular events in this quite small study. This is hypothesis generating. But even the Proteus trial, they had to make an amendment in the trial, and this is public information, to mandate baseline cardiovascular assessment to make sure there will be no increase in cardiovascular toxicity or thromboembolic events during the study. So I guess we will see more intensification of ADT and more treatments earlier in the course of the disease, which will, let's say, we will start giving this drug to more and more patients with increasing benefits in the oncologic perspective. They'll have to make sure that these patients are being carefully monitored by their cardiologist, so they will have the benefits, but not increase toxicity into these new treatments.
Super. And then, I think one of the main concepts that Dr. Briganti talked about was what you just mentioned about treatment intensification. So, that you have these newer therapies and they're more potent at preventing the progression of prostate cancer, but they certainly have cardiovascular impact. And, I think that the overall cancer or the overall survival benefit may be positive, it may be a good thing, but there are, that benefit is attenuated by cardiovascular adverse events. So I think how we do a better job managing those, going forward, I think is going to make have a big influence on those outcomes.
I want to add one comment is that I think Dr. Briganti also bring out a new approach to management is the metastatic directed therapy, because I think with the improvement in imaging now for those oligometastasis status disease, we can using say SBRT to treat the lesion. Maybe this will help to delaying the use of ADT and allowing less drug exposure. Hopefully, this may also help to improving the cardiovascular status of the patient. Yeah.
Yeah, and I think the other question, you know, one of the last slides or two, Dr. Briganti's presentation mentioned about using PARP inhibitors or potentially even checkpoint inhibitors. And, you know, for a cancer that's, you know, relatively slow growing, adding the whole checkpoint inhibitor piece to the equation is a little bit scary for me as a cardio-oncologist. I don't know if you guys have a perspective on that.
Yeah, so in general, the immunotherapy story in prostate cancer has not been very successful because usually this prostate cancer lacks good responses. We have like a series of negative studies with immune checkpoint inhibitors. There are new modalities of immune stimulation that are currently in phase 1 and 2, including CAR T cells, T cell engagers, and so forth. But I would say at this point, it's very rare for us to use checkpoint inhibitors in advanced disease, mainly for patients with microsatellite instability. Yeah. But I agree with you. I think we'll have to see a strong survival benefits to start incorporating more and more drugs earlier in the course of the disease, because at the end of the day, we want our patients to live longer and better with these drugs, but not to create more problems in the course of their lives.
I just want to say that, you know, immune checkpoint inhibitors now are approved for neoadjuvant treatment in triple negative breast cancer. And I can tell you, since I've been using them, it's a challenge that the toxicity, and I'm not necessarily saying just cardiovascular toxicity, but toxicity in general of these agents, particularly in older patients, should not be underestimated.
Yeah, no, I think that's an important perspective. And, you know, triple negative breast cancer is, you know, depending on what stage it is, you know, can obviously be very difficult to treat, and they may have had some other toxic therapies prior to that. So
great discussion, guys, but I think unfortunately we're gonna have to wrap it up. We are on the top of the hour. First of all, I would like to thank the speakers and the moderators for a great webinar. I think completely aligned with our initial goal. If you all remember, the title of this program was Prostate Cancer and Cardiovascular Disease, Principles of Optimal Multidisciplinary Management in Clinical Practice, really with the goal of discuss the state of the art and recent advances in the care of men with prostate cancer, and discuss better ways to apply the knowledge into clinical practice, as well as highlighting what is needed for truly in a collaborative approach, better treat these patients that are so challenging to be treated in clinical practice, as we all highlighted here. So I wanted to also remind the viewers about our online curriculum, which will be available online for 12 months, both at the ICO's website, but also at the Duke CME website. And the link will be sent to all participants. So feel free to share those with friends and colleagues, because I think these 4 webinars where we discuss so many different aspects from the state of the art in prostate cancer and also future directions, and the importance of the truly collaborative approach is so important for everyone who practice cardio-oncology. As well as the online curriculum, I want everyone to stay tuned on 2 different manuscripts that are being prepared with all the content of these webinars, and therefore this will be also a nice material that people can use in talks and use to discuss with residents and fellows and colleagues in their hospitals and their settings and their clinics. So stay tuned for those. Those are coming in the next few months. And then third, I wanted to thank my co-moderators of this webinar series, Dan and Darryl, for the great collaboration, as well as the truly international steering committee that we have people from all of the continents in a truly collaborative approach, truly illustrating how we should be practicing cardio-oncology and also studying cardio-oncology in clinical research. So really thank for everyone who participated and helped to build this program and make it real. And finally, I also thank Faring for the tremendous support in putting this together and supporting this effort, which I hope will be the first of many future similar programs where we can discuss high quality evidence, but in the light of clinical practice. So we can all share what we know, what we don't know, and how to try to close these gaps in the best way possible. So thank you very much for the attendees and for the speakers and moderators. And I hope to see you all soon in different meetings across the globe.
Fantastic. That was really good. That was such a broad description of what is going on, and really thank you for your summary at the end, and thank you, Anthony and Diogo, for moderating this session. It was really good. Really appreciate your input.
Agree. Thanks everyone. We'll keep in touch. Thanks. And
thanks so much.
Thank you.
Thank you, guys.
Bye bye.